Okay, guys, next we'll get into some other cardiac medications that you often see. So to treat hyperlipidemia or hypercholesteremia, you'll often see the use of HMG CoA reductase inhibitors, also known as statins. The common suffix for this family of medications is exactly that, statin. So anytime you see this suffix in a generic medicine, you can think is the medication to treat cholesterol or LDL cholesterol specifically, remembering that LDL cholesterol is what affects endothelial function. That's what ends up getting infiltrated into that uh, vascular intima, and creates those foam cells. So if we can reduce the amount of LDL, we can reduce some of the oxidative stress on the endothelium and prevent the proliferation of plaques, right? Because if we have more LDL circulating after a plaque's formed, it's only going to continue to grow. So if we reduce that, we can reduce the progression of cardiovascular disease and even reverse it to some degree, but really aimed at preventing it from getting worse. So the blocks LDL synthesis, increases HDL, which again, you can think of those little scrubber bubbles that eat up and transport LDL to the liver to be metabolized. Now, the most common ones you'll see out there are lovastatin or Mevacor, simvastatin, also known as Zocor, and then atorvastatin is probably the most common one. Lipitor, you gotta love how creative chemists get with their names. Lipitor, right, for the brand name. And then rosuvastatin, again, statin, dead giveaway. It's the common suffix for this family of med, HMG CoA reductase inhibitors, also known as statins, which treat hyperlipidemia by blocking LDL synthesis. Now, we've got different criteria. Don't need to know that. It's just something you may see when physicians are deciding when to prescribe a statin, who may benefit from it. Now, it's interesting. We're finding that statins may the effects may go beyond just reducing LDL cholesterol. We think there's some anti-inflammatory properties to this. And in fact, there's been some push now to not even track cholesterol once the patient's necessarily on it, like are using that as a criteria to determine whether the drug was effective or not. Almost being by nature of patients with heart disease or plaques being on a statin, it's going to reduce mortality. So it's an interesting relationship where our knowledge of how these meds work are constantly evolving. And again, the goal is to block LDLs. We're finding it maybe go beyond just LDL reduction, and that's usually not as much the goal just to get it down. The LDL cholesterol should decrease, but that may not be the exact goal for a lot of patients. Now, a little bit of a caveat about myopathy in statins is something that's often brought up. Well, statins can lead to rhabdomyolysis. So rhabdomyolysis with statins is actually incredibly rare. It's about like less than 0.1% of patients have full-blown rhabdomyolysis, which again, that classic triad of pain, muscle pain, weakness, coke-colored or dark urine, which is due to when you have rhabdomyolysis is muscle death and rupture and our tissue rupture, and those enzymes get into the blood, which lead to that, that darker colored urine because those enzymes have leached. Now, very rare with statin use. If we do see it's going to happen probably in the proximal muscle groups, thighs and shoulders. You may see some swelling in the limbs, cramps. That's kind of common with rhabdo in general. Now, while rhabdomyolysis is incredibly rare with statin use, full-blown rhabdo, myalgias and weakness are actually pretty common. They're about 7%. Some say as high as, or myalgia may by itself may be as high as 25%. And we think, there may be some changes that occur in the muscle, but full-blown rhabdo, is a side effect of statin use, but it's actually incredibly common. Myalgia, also common, but that's not the same thing as rhabdo. They may have some muscle pain, but it may not be due to full-blown myopathy. Next, we'll get into diabetic medications. We're going to move through these kind of quickly again, just because you'll learn a lot more about these later on. So we've got sulfonylureas, also known as insulin secretagogues. These increase insulin by interacting with potassium channels in a beta cells. These are used for patients that has type 2 diabetes that still had some endogenous insulin production, right? So they can still produce some insulin. This is helping us ramp up a little bit of insulin production. So that's what a sulfonylurea is. You'll see those as glybutride or glinase. It's a short-acting, long-acting lipitrol, glucontrol. Most of your diabetic medications will have gluc somewhere in the name, or the brand name, or even the generic name. Now we have biguanides, which it helps increase or improve insulin sensitivity, and improve like glucose utilization as well. So it helps us get the glucose in the blood into the cell. So we increase insulin sensitivity, its ability to uptake glucose that's in the bloodstream, uptake it into the cell. And also these help reduce the production of hepatic glucose production by lysine, glucagon, stuff like that. The most common one you'll see is metformin. Generic name, also known as glucophage. Again, there's also an extended release, glucophage XR. Again, these help uptake insulin, or help uptake glucose from the blood into the cell by increasing the sensitivity of insulin. So this is for those patients with insulin resistance, type 2 diabetes, right? So not going to be super effective for patients with type 1 who don't really produce insulin. So this is often used for your type 2 diabetics. There are also incretins or glucagon-like peptide 1 receptors. These help amplify the release of insulin when we have like glucose intake. So again, when we typically eat like insulin spikes, right, to help uptake that glucose in the blood into the cells, after we eat something. So this is given to help facilitate that, amplify that. These are popular because they don't cause the same amount of hypoglycemia that you might see with like incretin, stimulated insulin secretion, like our examples in other meds like that. So these are the dead giveaway for these are the suffix glutide, so abloglutide, duloglutide, exenatide, all these here. Glutide is a dead giveaway for these glucagon peptide, so glutide receptors or incretins, right? So again, these don't cause much hypoglycemia because it's still kind of working with what the body already sort of does. It's just amplifying the effects. So you have less of those hypoglycemic episodes as you see with a sulfonylurea. So these are maybe a little safer than some other meds, but metformin is still pretty common. Now, insulin therapy, right? So insulin therapy, it's going to be primarily used to treat type 1 diabetics who don't produce insulin, right? They need they need insulin shots or injections to have any. You may see it in a type 2 diabetic if they become, again, that we call a insulin dependent type 2 diabetic, or someone with just really poorly controlled type 2 diabetes, or we call it insulin beta cell burnout, right? Now, there are multiple different types of insulin, right? And where we apply it, is it going to be in subcutaneous tissue? Is it going to be in the muscle? Is it going to be an injection in the abdomen, the arm? All that's going to affect how it's absorbed. We talked about that in the beginning, in the background lecture. The concentration will affect how or the volume of the drug. That's going to affect how quickly it responds, or as well as the local blood supply into that area. Now, there is rapid-acting insulin aspart, fast-acting, it's just regular insulin, Humulin, and Novolin, and there's long-acting Lantus, which people kind of use, over the day. So quite often patients will have a bit of both just to keep on them in case their blood sugar, spikes. They need to take some insulin or take a little bit before exercise or adjust it. A lot of people are you'll see with these. I skipped over a few things here. Sorry. You'll see with these devices is an insulin pump that has a glucose sensor, and then if it senses blood sugar going high, it will cause the device to release. Sorry about that, guys. Did not expect to stop there randomly. But like I was saying, these insulin pumps will have a sensor. It'll sense that the blood glucose is too high or too low, and it'll adjust the intake again of the administration of insulin. So bit of a point of controversy in the diabetic community, because there are some devices that can be programmed to be a little bit more effective, or different issues with costs. So it's actually a bit of a controversy on regulation of these devices, and then expense. So these are very, very, very important for your type 1 patients with type 1 diabetes. So again, glucose sensor detects, does it dip? Does it go up? If the blood glucose goes up, it'll automatically administer insulin to keep blood sugar consistent. Now we'll get into some antithrombotic medications. So the first ones we'll talk about are anticoagulants. So there are different types of antithrombotic meds. Anticoagulants prevent the coagulation of blood, and they act on different parts of the coagulation process. So unfractionated heparin, there's low molecular weight heparin, and then warfarin. So unfractionated heparin, or UFH, blocks clotting factors in the blood, traditionally through an IV med. You may see this given to patients post-op to prevent blood clots, or maybe even someone who has an acute blood clot or VTE. Low molecular weight heparin, this is also has a generic name of enoxaparin. That goes by the brand name of Lovenox. This has very similar effects as unfractionated heparin, but it's a smaller, lower molecular weight, so it might be a little bit easier, or the effects maybe are a little bit faster. And it's typically used in patients with better kidney function, though. So if you have, again, a lot of this goes back to your liver function, your kidney function. That's why it's so important to have pharmacists that are very just mindful of how these meds act on different parts of the body. So that's why it's great to have a profession that just focuses on that. But so unfractionated heparin, low molecular heparin, very similar effects, either prevent blood clots or used to treat someone with an acute blood clot. Low molecular heparin is often given as a subcutaneous injection. You may see this in a hospital. Someone, after a hip replacement, for example, with high risk for clots, will have these purpura, right, or purple marks on their abdomen. You might be wondering, what is going on here? That's often from the heparin that they had injected into their abdomen, into the muscle or the tissue there. And then we have warfarin, also known as Coumadin, which blocks the vitamin K reductase. This is used for long-term anticoagulation for patients maybe with chronic DVT, AFib. I had that twice, but again, we talked about how the risk of clotting in patients with AFib. Now, on the market now are these newer types of anticoagulants called NOACs, which stand for non-vitamin K antagonists or oral anticoagulants. So NOACs, vitamin K oral anticoagulants, so NOACs. Their dead giveaway is Zaban. So there's rivaroxaban, apixaban, edoxaban, and dabigatran, or Pradaxa. These are direct-acting meds that block either tissue factor 2A or activated factor X or XA. Very similar effects as your vitamin K anticoagulants like warfarin. These are great for long-term use. We're seeing this even starting to be used on for VTE prophylaxis. But the great thing about these is they have very low drug-to-drug interactions. I think warfarin has like 32 or a ton of meds that it interacts with. So it can, especially like grapefruit is a big one. So this is great because there's less side effects from interacting with foods, and there's a very wide therapeutic window. So often patients on warfarin, which again they use for long-term use, have to come in the clinic to get their different blood values checked, their INR checked, which is we'll learn about later, to see if they're beyond or within that therapeutic window. With these, they don't really need that, so it's a little bit safer to use. There's less major bleeding incidents as well. So you're seeing these used more and more where warfarin had been used previously. And again, this is an example of just where these meds act on different tissue factors. I'm not expecting you guys to know all this, but just gives you, a little reminder from physiology. Again, these different routes of administration. So now, antiplatelets, similar again, they're antithrombotics, but they act on platelet aggregation, right? So they don't really necessarily stop platelet production per se, but they prevent them from aggregating. So the most common one that you'll see, acetylsalicylic acid, or ASA, or also known as aspirin, used for a lot of different things. It is often used in low doses, again, that's antiplatelet med, or antiplatelet aggregant to prevent, again, clot formation, right? So, and there's also some anti-inflammatory effects too from aspirin. It's often given in large doses in the patients with an MI, and we'll go over that in a bit. And then it's often prescribed with clopidogrel, often as Plavix by the brand name, which also acts on preventing platelet aggregation. Quite often, these will be given together, so patients will be prescribed a low-dose aspirin and Plavix together. And we call this dual antiplatelet therapy because they kind of work well together, and it's often used after stenting. We talked about those issues with bare metal stents and clotting, as well as even with drug-eluting stents. You may want to prevent the risk of future clots when we have a metal prosthesis inserted into the body. So is a common combination, these two meds. Then we have thrombolytics, which again, these aren't going to prevent clots. They're going to lyse clots. They're going to break them up. So again, thrombo, clot, lytic, lyse, to break. The most common one you'll see is tissue plasminogen activators, or TPA, which have a suffix of kinase. Most common one you'll see there is streptokinase or streptase, or urokinase, avenase. Basically, facilitate enzymes really, which break down clots already formed by converting plasminogen to plasmin. So these break up clots. These sometimes are used in patients with a stroke or in patients with an acute MI when they can't get them to the cath lab. Remember, we said the goal for an ambulance, right, and someone's got an acute MI, is to get them into the cath lab to have that balloon angioplasty placed in to open up that artery, stent in or not, in 90 minutes, right? Sometimes if you're far away, like in a tertiary hospital in a rural area especially, there might not be a cath lab available for 3 hours, right? So they, and we're working to get better at that, but they may be given a thrombolytic, at a lower level hospital, stabilize the patient, and then transfer them to a trauma 1 hospital or a trauma 2 hospital that at least has a cath lab available, because not every hospital has an interventional cardiologist. And then we'll get into some anti-rhythmics. Again, I'm not expecting you guys to know all the physiology for these specifically, but there are different classifications. So class 1s are sodium channel blockers, lidocaine, a common one. Beta blockers are typically class 2. Again, beta blockers have some membrane potential stability. Calcium channel blockers, amiodarones, very potent one, actually acts on both sodium and potassium channels. And then calcium channel blockers also can stabilize membrane potentials because really realistically, a lot of these act on these sodium, potassium, and calcium channels by affecting the ion concentrations moving across the membranes, which helps stabilize it in one direction or the other. Most of these operate by either decreasing node rate or decreasing conduction velocity or helping stabilize the membrane potential. You may see adenosine used to treat supraventricular tachycardia, SVT, and then atropine used to treat bradycardia, which if you guys are familiar with the deadly nightshade, that's where atropine kind of comes from, nightshade. And then meds for acute coronary syndrome. So we've got groupings here: anti-agenals, so sublingual nitrogen, probably the most recognizable one. That's given under the tongue. Remember, we talked about in the initial lecture, nitrogen has a very short half-life. It's a very volatile substance. And if we give it to someone orally, it's going to be completely metabolized before it ever gets to the bloodstream. So we got to get it, rapid acting in someone with a heart attack. you're not going to have an IV on you, so you're going to give them a sublingual tablet that will dissolve in the tongue. You actually hear it spark, like, or not spark, but fizzle, like pop rocks, basically. That's how you know it's still active. So it should fizzle when they put it on their tongue if it's active. It's given in patients with angina, that unstable angina type. Some patients even carry it around who have stable angina if they ever get chest pain. Typically, cardiac rehab facilities will have this handy just in case anyone goes into or is at risk, right? They have a little bit of chest pain. Now, it's very rapid acting. It's a very rapid acting vasodilator, right? So it's always important that patients take it when they are sitting down. One, because it's going to reduce afterload, so it's going to make it, the systemic vascular resistance will drop, may drop blood pressure as well. It's more potent on acting on the veins. Remember, your veins have a wide capitate, so your veins dilate and pool, so you're also going to reduce venous return, so patients can really get dizzy. If they take it standing, they could fall down. You have two problems instead of just one. So make sure patients sit down when they take it. And every protocol, every facility has different procedures or for time frequency. Typically, you probably will never be administering this, but generally it's given every 5 minutes and at max typically 3 before you're going to call like an ambulance. Some facilities say the first time you administer, you should probably call an ambulance. So every place is a little bit different. Biggest thing though, make sure the patient sits down and that they don't take 3 in a row and they'll bottom out their blood pressure and pass out. Again, the problem with any emergency situation is to prevent other complications in addition to your emergency situation. Aspirin's often given in acute coronary syndrome. Again, it's a platelet aggregate pain relief. So often patients are told if they have chest pain, if they don't have nitros at home with them, get 3 or 4 aspirins, chew them up, and then wait for the ambulance to get there. Morphine is often given in an ambulance. It's a vasodilator. It also helps reduce pain and anxiety, which will only make the heart work harder. If someone's in acute coronary syndrome, we want the heart to kind of calm down, right? So its demand isn't going up. Remember, angina, ischemia, right? Or ischemia, angina, which is due to ischemia, and ischemia is all due to a supply-demand imbalance, right? So if we've got impaired supply because of a blocked coronary, well, if we can keep increasing demand, it's only going to make that imbalance worse. So we need to, try to bring the anxiety down a little bit, bring the pain down maybe a little bit too, and keep them calm while we get them to the cath lab. Beta blockers often maybe be given acutely. They also help reduce myocardial oxygen demand, that MVO2. Definitely given afterwards, prevent that remodeling, but acutely can also help prevent those deadly arrhythmias. Supplemental oxygen you might see given to patients. You'll learn a lot more about that in the pulmonary unit. And then anticoagulants if they're going to get stented, just to prevent any clots forming, when they're getting a stent placed. Post-MI patients will be given an ACE inhibitor typically, maybe again that beta blocker to prevent that remodeling. And then if they weren't on a statin already, they will be put on a statin. Really pretty much anyone who has an MI or acute coronary syndrome is probably going to be put on a statin just because of the risk reduction and mortality reduction. So that's cardiac pharmacology in a nutshell. Again, you're going to get a whole entire course on this. This is just a little bit of a crash course. We're going to touch on some of these concepts we already have in previous units, but so I'm going to have a little bit of review here for you guys. So that will be what's cardiac pharmacology. And we saved the heart failure meds to a later lecture because it's a whole kind of a different process altogether, different intention.